to another episode of Burning Migraine Questions. My name is Zeev Pellet. I'm a plastic and peripheral nerve surgeon with a focus on headache and migraine surgery here in the San Francisco Bay Area. Thank you so much for joining us. We have a lot of very interesting questions as always and a lot of ground to cover. So I wanted to introduce myself and just get right to it. One of the more interesting questions that I actually received just a few days ago was from a woman who actually said, I had a nerve block done about a week or so ago. I still haven't seen any benefit. How long should I wait? Or is it reasonable to wait before you know whether a nerve block has worked? In other words, how long does it take to kick in? I think this is a very good question because there's several components to the nerve block that are really important. When most physicians do nerve blocks, that is most neurologists, for example, I certainly can't speak for everyone, but the majority of practicing neurologists, for example, will do an occipital nerve block. And the nerve block cocktail is actually a combination of two main types of medication. One is a local anesthetic, which should hopefully numb the nerve and actually helps to decrease the pain of the injection to some degree. The other is very often the addition of some type of steroid. And there are many different kinds of steroids with varying potencies, which you can all Google. But the idea behind that cocktail of agents is to give you some medication to immediately numb the nerve, as well as some medication to hopefully tamp down any inflammation, because steroids are some of the most potent anti-inflammatory agents that we have. So the question that this patient raises is interesting because it actually depends on which of the components of this type of cocktail you are talking about. If you are expecting some type of immediate relief, so let's say you had compression of the greater occipital nerve and it was causing occipital neuralgia that may or may not have features of migraines and may or may not have been diagnosed as migraines, and you block that nerve with a local anesthetic, whether it's lidocaine, marcaine, ropivacaine, any number of the local anesthetics, you should experience numbness within a few minutes. So if the only substance in the nerve block was a local anesthetic and it's a week later, very likely that nerve block was unsuccessful because you should have noticed some numbness fairly soon. If the pain relief lasts for several weeks or several months, that is very likely the steroid component of the injection that you received, and the steroids actually help tamp down the inflammation, and presumably you had some neuritis. Any itis is an inflammation of something, so neuritis is an inflammation of a specific nerve. And if you had neuritis of a specific nerve and you injected a steroid in that area, it should diminish that inflammation and make you feel better. Now, typically, the results don't last a few weeks or a few months. They typically last a few days, if you're lucky, a few weeks. And then, of course, the problem becomes that you can't inject steroids, certainly not at the doses that most people use them, every few weeks to hopefully feel better. So the hope when you inject a steroid with a nerve block is that you'll get at least, let's say, 3 months of relief, because steroids, obviously, depending on the potency, can probably reasonably be injected every 3 months fairly safely. So it is a very reasonable strategy if you have an injection in the last 3 months where you really control your pain. So let's say the pain is diminished 80–90% for 3 months and then starts to come back. Sure, you can get a steroid injection nerve block every 3 months. Unfortunately, they almost never work that way. And so that gets back to what I tell my patients all the time, which is that nerve blocks, whether they contain steroids or not, are really better utilized as diagnostic modalities instead of treatment modalities, because typically when the effectiveness of the medication that you're given, whether it's the local anesthetic lasting a few hours or even a couple of days in some cases, or the steroid, which can last a few days or in some cases a couple of weeks and months and rarely a couple of months, when the effectiveness of that medication goes away, the problem will still be there if the problem is a mechanical compression. And again, the analogy I give to women especially, since most of these patients are women, is that if I stabbed you in the foot with a dagger and gave you an epidural, would your pain get better? And the answer, of course, is yes. You wouldn't be able to walk. You wouldn't be able to feel your leg. You might not even be able to feel that you needed to urinate, because the sensation to the bladder from typically the belly button down if you get your average epidural like you would when you're pregnant and about to give birth, is actually effective. But as soon as you turn that epidural medicine off, you're going to scream bloody murder because, of course, the knife is still there. So giving somebody an epidural has not fixed that problem. It has just masked the problem. And if an epidural was, which it's not, if it was focused on a specific nerve, then you would have been able to diagnose that it is that nerve that probably contributes to a lot of that pain. So hopefully that helps. There was a really interesting question here by a patient that said they had surgery with one physician back in March of 2016, and then they had pain relief for 1 year, and then the headaches are back nonstop. And the question was, how long do you allow this new situation to calm down before seeking additional help for a decompression, another decompression, or a transection of the nerve? So the first recommendation I have for people like that, and these are all general recommendations, of course I haven't seen this person, but is to always go back to the physician that actually did your operation in the first place. They know you the best. They've hopefully done a reasonably comprehensive workup before your initial operation, and they were certainly there during your operation, so they know exactly what they did, if they cut a nerve, where they buried it, if they potentially saw another branch of a nerve that they may have left alone. I saw a woman yesterday who had a decompression of one branch of the lesser occipital nerve and a transection of the other one, and she continues to have pain in that nerve distribution, so it seems. And it's very likely that remaining branch that continues to cause a problem. So if I was the surgeon in that operation, I would have a much better sense of whether or not that is likely to be the case. So the first thing to do is always to go back to the initial surgeon and see what they have to say. And if you trusted them with an operation the first time, they likely have hopefully a reasonable explanation as to what's going on persistently and what else they could offer you. I think the question then also becomes, what is the character of the residual pain or the recurrent pain in this case? Is it exactly the same type of pain that you had before, or is it different? Meaning, is it in a different location? Is the character of the pain more of an aching as opposed to a sharp shooting, or hyperesthetic, meaning a hypersensitive type of discomfort? Those will also clue you in as to whether it is a nerve or a persistent nerve. Let's say you left the greater occipital nerve on a particular side. Perhaps it is that residual occipital nerve that has always malfunctioned, and you made a decision in the operating room as the surgeon that that nerve would likely function better once it was decompressed and given a little bit of time. But of course, no one guesses right 100% of the time, myself included, and every once in a while you do an operation, you decompress, for example, the greater occipital nerve, and what you're left with is residual pain in that nerve distribution, or recurrent pain in that nerve distribution. The other question is, are there other nerves that perhaps weren't addressed during that initial operation? So for example, there are a number of patients that will say, I had my greater and lesser occipital nerves operated on, and now I still have a lot of the similar types of pain. Maybe it's slightly less, but not a lot. And when you examine them, it seems like they have third occipital neuralgia. And as I've stated in conferences and in teaching conferences that I give, the third occipital nerve is almost always in the way during the dissection for the greater occipital nerve. It lies very superficial to the same area that you'll find the greater occipital nerve in. So it is very likely that when you operate and look for the greater occipital nerve, you have run across or are retracting to the side the third occipital nerve. So anytime I see somebody that's had greater and lesser occipital nerves worked on with no mention of the third occipital nerve and some residual posterior midline pain, they very likely have third occipital neuralgia, which either was undiagnosed or which was a result of the initial operation because the operative surgeon did not notice that the third occipital nerve was present and either cut it, leading to an neuroma, or retracted it, leading to a traction injury, and therefore the patient still has pain in a similar area. So it can be confusing. There is a question about, do you need to have a recent MRI of the cervical spine? Again, this is a question that comes up a lot, and the simple answer is no. The more involved answer is, it's important at some point, especially if you have a history of trauma, and especially if you have any upper extremity symptoms, meaning anything from the shoulders to the fingertips. And what I'm not talking about is, well, you know, sure, every once in a while I fall asleep on my hand and it goes a little numb. Everybody has that, and that's very normal. As soon as you lift your head off your hand and off the pillow, the sensation and function comes back. That is not what I'm talking about when I say, do you have upper extremity symptoms? I'm talking about consistent and predictable numbness, tingling, shooting pain. You know, a lot of patients that I see will say, yeah, you know, my fingers from the thumb to the ring finger are pretty much numb the whole time, and every once in a while I'm holding a coffee cup and it drops on the floor, or I'm holding a pen with my right hand because I'm right-handed, and next thing you know, it's I'm writing very poorly because I don't seem to have good control of it. That's someone that actually could have something called neurogenic thoracic outlet syndrome, which is a compression of the nerves coming out of the cervical spine that go to the upper extremity. And you can, in some of those patients, have occipital symptoms, for example, or jaw pain. And it is those patients that require a slightly more extensive and more nuanced workup to determine the cause of their headaches, even if that's not the primary complaint. So do you need to have a recent MRI of your cervical spine? As my Israeli colleagues and family members would say, it's depend, right? So if you had a history of trauma in the past, and you've had a cervical MRI since that accident, let's say, and it has shown nothing, and you've seen a, let's say, spine surgeon, neurosurgeon, they say there's nothing in your cervical spine that has any bearing on the symptoms that you're experiencing, and you then see me a year later and nothing else has changed, then no, you don't need another MRI of the cervical spine, because it's highly unlikely that a disc has herniated since that time. However, if you have a car accident, you have an MRI of the cervical spine, it shows nothing, you see a spine surgeon, they say there's nothing here that's causing your headaches. 6 months later, you have another car accident and another whiplash injury, and then come to see me and say, yeah, I'm having these headaches. They were minimal before the first car accident. They got worse after the first car accident. After the second car accident, they're a lot worse. Then yes, that person will need another cervical spine MRI, because with that second whiplash or car accident injury, things could have changed that might be impacting the symptoms that you're perceiving. So again, there's no one answer to that question, but I think it's an important one. There's a question of, have I seen more bleeding or pain control issue in redheads? There is some data out of the dental literature, and I think we may have covered this at one point in prior Burning Migraine questions episodes or in one of my blog posts, but there's a little bit of evidence from the dental and oral maxillofacial literature that says redheaded patients have a slightly higher risk for bleeding complications. Personally, I have not seen this. That concept is somewhat controversial in that there are a couple of studies. They were small but reasonable studies that showed that there were increased bleeding risks because of certain genetic mutations in the coagulation pathway in redheads as compared with other patients. But subsequent studies have not borne the same fruit and revealed the same results. So the jury is still out on that, and I can only speak for myself, obviously, and say I have not seen any increased risk of bleeding in redheaded patients compared with brunettes and blondes, for example. There was another patient that says, how far can a lead migrate if you, let's say, get into a car accident after you have a spinal stimulator or peripheral nerve stimulator implanted? Again, there's no simple answer to that question. This person was wondering, isn't there an anchor that will kick in and stop it from going too far? And of course, the answer is no. You can rip those anchors out of the tissues that they're embedded in if you have a severe enough injury. So if you have a peripheral nerve stimulator, let's say an occipital nerve stimulator, and you are the driver of a car and are rear-ended and you fly through the windshield because the car that hit you was going 50 miles an hour, you're likely going to tear lots of different things, including potentially the anchors where the lead is located. And it's one of the complications of peripheral nerve or spinal stimulators, and that the leads can move. In addition, the neck is an area of constant motion, whether you're looking up, down, side to side, etc. And so leads, in terms of the anchors that are supposedly holding them in place, can migrate and move just or loosen up with time, and therefore the leads can migrate. Now, the other follow-up question to that was, how far can a lead migrate, or should a lead migrate before the lead no longer works? And again, it depends on the settings of the stimulator, because of course, if you have a lead in one place, you have kind of this zone of treatment around it because of the electrical current that is going through it from the generator. That's where the battery is located on these stimulators. And if the lead migrates far enough from the nerve that it's supposed to be treating, it will become ineffective no matter how high you turn that knob. So you can turn it to 11 out of 10 and it still won't work. If it remains close enough but migrates a little ways away, and you can turn up the settings on that stimulator, you may still be able to get some effectiveness out of that. But it is a complication of peripheral nerve stimulators or spinal stimulators, as anyone knows. Let's see. Does the cause, this is a very important question, does the cause and duration of one's pain affect potential outcome? The answer is absolutely 100% yes. The degree of trauma that you might imagine from, let's say, standing up too quickly and hitting the back of your head against a drawer that might have opened while you were bending down to get something from a lower cabinet is a lot less than the degree and magnitude of the trauma that you might experience if you're the driver of a car or the passenger of a car that gets rear-ended and you fly through the windshield. So the impact and mechanism of injury, in terms of the degree of injury, the pressure, the amount of traction that might occur on any particular nerve, is certainly likely to be greater in that second case than in the first case, okay? In addition, while no one has shown this specifically for occipital nerves, for example, we know from the general peripheral nerve literature in the extremities, meaning the arms, the legs, which has been around for decades, that the longer a compression is present, the more damage to the actual nerve you get. We know that after a certain period of time, the myelin sheath, which is the coating of the nerve that helps nerve impulses propagate at a very reasonable rate so that we can react almost immediately. For example, if you touch a hot stove, you probably pull your hand away before you even think, oh gosh, that's hot, I should really move my fingers away. If you lack that myelin sheath, you might actually burn your fingers pretty significantly before you think, oh wow, that really hurts. So among the first things that happen if you have compression that is untreated for some period of time is that myelin sheath thins and the nerve impulses don't propagate quickly enough. Okay, with longer periods of time, the actual neurons themselves, those are the nerve cells within the nerve. So if you ever see any of the pictures that I or any of the other surgeons out there post on their websites or on their blogs, and you can see a nerve, that nerve is actually a bundle or collection of probably billions of individual nerve cells. With prolonged pressure that is untreated, the individual nerve cells themselves begin to die out. And as pressure continues to be present, you actually choke off that nerve, and the inside of the nerve is often replaced by scar, much like what happens when you have a heart attack. That heart muscle dies and is replaced oftentimes as the body processes that dead tissue by laying down of collagen or scar. So as you can imagine, if someone's had compression for 2 years, just to pick a number off the top of my head, the degree of pressure on that nerve was relatively light, they may have very little to no symptoms at all, and most of the myelin sheath may still be present, and most of the neurons within that nerve are likely still viable. If you take that situation and change it a little bit, and you say this person has had very severe pressure for 25 years, very likely that myelin sheath has been significantly degraded, and the number of viable neurons, that is, again, nerve cells within that nerve, is likely to be a lot less. So what does that mean if you were to operate on both of those patients today? Well, number one, that first patient is likely to have recovery much more quickly because the amount of damage to that nerve has been a lot less in the 2 years than the amount of damage that has occurred in that second person in the last 25 years. In addition, again, no one has proven this true with the occipital nerves, but if the number of neurons that are viable in that person that has only 2 years worth of damage is much greater than the number of viable neurons in the person with 25 years of damage, the ultimate degree of recovery will also be less, because even if I operate on that person with 25 years of symptoms today and the nerve miraculously heals in 5 seconds, as soon as I'm done closing the incision, there will actually be fewer viable neurons in that nerve to come back to life, so to speak. So the degree of pressure, the degree of sensation or the degree of function, if it's a motor nerve, will ultimately be a lot less in a nerve that has been compressed for a longer period of time and with a greater degree of compression compared to a nerve that's been compressed for a shorter period of time with a lesser degree of compression. Very, very, very important question. This person then goes on to ask, which again is really more of a value judgment, at what level of pain would you say the risk of surgery is not worth it? I always kind of go back to the data, which is what you see when you see a patient, when you go over their history and what they tell you when you have nerve blocks. If you are still having significant pain, clearly there is some function within that nerve. It is malfunctioning, which is why you're having pain as opposed to just the sensation of somebody touching you or even just numbness. Which might suggest that a nerve has now completely died off. And you see that in the diabetic neuropathy patients quite a lot. You know, these people will begin with intermittent numbness and tingling, and after a few years it's constant numbness and tingling, and then it can actually progress to frank pain. And if left long enough, their feet may go numb. And that just indicates that those nerves have completely died out. And at that point, surgery doesn't make any sense, because decompressing or even transecting a nerve that died a year ago is like doing CPR on someone that died a month ago. They're already dead, so all the compressions, all the chest compressions in the world are not going to bring them back to life. However, if a person's having pain, that suggests that there is still a viable nerve there that is malfunctioning and thereby causing the pain. And if they have a good result with a nerve block, again with an appropriate history and physical examination, I would argue that there is still some potential utility to an operation. And of course, at the end of the day, it's really a value judgment. If the person doesn't feel that they're going to get enough relief, or if their degree of relief from the blocks is, let's say, only 30%, and they don't feel that that's worth it, then assuming everything else has failed, then I wouldn't operate on them either. And it's part of the more nuanced discussion that you have when you see these patients. I think that's a very important component of the discussion that you have to have in the pre-operative setting. One final question that we have time for: what is the biggest risk of an excision? I would say there's a couple of risks. Biggest, I guess, depends on your perspective, as always. If you transect or remove part of a sensory nerve, you will likely have numbness in that nerve distribution. That's not always true, because some nerves are redundant. In other words, if you take this random period or a piece of skin and you have 3 different nerves that come into that piece of skin and you cut one of those nerves, you still have those other 2 nerves that are going there. And so if you touch that area of skin after surgery, you're going to perceive, hey, I still feel it, feels normal. So you don't always get numbness if you cut a nerve, and that's very common, for example, for the zygomaticotemporal or third occipital nerves, because there are other nerves that also provide sensation to the same area, and they're actually much larger nerves. So you often don't miss those nerves, so to speak. The other component of an excision is if you excise or transect a nerve, because remember, we're not cutting it out like we're cutting out a breast mass. We are transecting it. We are cutting it upstream from where we believe there's damage, so that the cut end of the nerve is actually healthy. You then have to do something with that cut nerve, because that cut nerve, you haven't ripped out of the spinal cord and brain. It is still attached to the spinal cord and brain, so impulses will still flow through it, and it's kind of like a live wire Think of it as a down power line that you might see on your street after a storm. If you touch that, you're going to get electrocuted. If you touch the end of that nerve, you may still experience pain. So you have to do something with that nerve. The most common thing to do is to transect that nerve and bury it in the muscle. But there are a number of other things that you can do to that nerve to help it calm down. For example, you can do an end-to-side neurorrhaphy, so repair it to another nerve to hopefully give it something to do. You can try to neurotize specifically a piece of muscle, which is in effect what you're doing when you bury it in the muscle. I was just part of a panel for high volume nerve surgeons just this past weekend, and there is a brand new device on the market called a nerve cap, which is supposed to help the nerve calm down if you have to cut a nerve. And again, we can discuss that more in future episodes of Burning Migraine Questions. Unfortunately, I have to cut out a little bit early today. We've only gotten to a few of the many questions that people have sent in. Please keep them coming. They're always great questions. They're always new questions and even important repeat questions. You probably never hear enough of the same answers, and eventually the concepts will hopefully cement in. In addition, I was actually told by one of my patients that she did her own Facebook Live not too long ago, and I don't know how many people tuned into that. So I've asked her if she wants to do another Facebook Live with me, and hopefully we can have a more nuanced discussion and a more in-depth discussion about what her symptoms were like before and what they're like now that she's several months out from her operation. We've not set a time for that yet, but keep your eyes and ears open. If you follow us on Facebook or Twitter or Instagram, we'll hopefully have notifications about when that's going to happen, and hopefully we'll see you there. Thank you very much for joining me on this session or this episode of Burning Migraine Questions, and we'll hopefully see you again in the future for another episode. Take care.